Welcome to Mom in Mind, where we dive into all aspects of perinatal mental health and wellness related to pregnancy, birth, loss, postpartum, and new parenthood. It's so much more than postpartum depression. We raise the volume on all of these topics in the hopes that someday everyone will have the support and info that they deserve before they need it. Please note this podcast is not a replacement for treatment by a professional or professional training. Welcome to Mom in Mind. I'm your host, Dr. Kat. We are going to be taking a really close look today at the experience of both babies and parents who go through the NICU. There's so much to know in this conversation, and Dr. Mara Tesler-Stein is going to help us understand some parts of this. So for those of you who have had an experience with your child in the NICU or your experience through the NICU, this might resonate for you. And I'm also hopeful that for those people who haven't had these experiences, that we can understand a little bit more deeply and have more compassion and understanding for the experiences of these babies and parents. Dr. Stein is bringing a wealth of information and knowledge from her years of experience, both personally and professionally. Mara Tesler-Stein is a psychologist in private practice specializing in the emotional aspects of coping with crisis around pregnancy, parenting, and medical crisis, child development, and relationship-based and developmentally supportive care to babies and their families. She is a certified EMDR therapist, EMDRIA Approved Consultant, and is an EMDRIA Approved Trainer for the Insitute for Creative Mindfulness. She's certified in other modalities like emotion-focused family and couple therapy, is Gottman Certified Therapist, and continues to pursue training in Clinical Hypnosis and Ego-State therapies. She's really bringing a wealth of clinical experience and insight, along with all that she's learned from interviewing families around the world, from her 2 books, to her EMDR Basic Trainings and Advanced Practice Workshop, all of this grounded in her personal experience, which began 25 years ago and took her through infertility, twin pregnancy, prolonged hospital bed rest, the NICU, and nearly 23 years of raising NICU graduates. What I'm really excited about in our episode today is we're going to be talking a little bit more deeply about what happens for the babies in the NICU and some of the experiences they might have and how that interplays with the experience that the parents are having. So for people who've gone through this experience, you can better understand why you might feel the way that you feel. And for those of us who are supporting parents through the NICU periods, we can understand more deeply how we can support parents and babies. So let's start our conversation and meet Dr. Mara Stein. Welcome, Mara. Thanks so much for being with us.
Thanks, Kat. It's really a pleasure to be here. Such an honor. I love your podcast.
Oh, thank you. I'm really excited to talk to you because you are a wealth of information. And I think what you're going to share with us today is really going to help a lot of people who listen to this podcast. So yeah, I'd love for you to just start off with the work that you do.
Okay. So I'm a clinical psychologist and I'm in private practice, but over the years I've done quite a bit in addition to my private practice work. I got into this specialty when I was already a psychologist, and I was a child and adolescent specialist back then, but I was always drawn to working with trauma and with grief. But it was my own journey, my infertility, and then a twin pregnancy, preterm labor, hospital bed rest, and preterm delivery, and a NICU stay. It just really opened up for me how much was missing, how lacking these emotionally aware, nuanced resources were for parents. It was really striking. I felt like either there's something really wrong with me or we need more here.
Right.
What was going on? Mm-hmm.
I so appreciate that you just said that because I feel like that is such a common experience across the board for perinatal mental health. And like the transition is like, is this me or what is going on here?
Yeah, you look and you scour. And my twins are almost 23. So it was quite a while ago, and so the resources were harder to find.
Yeah.
But it's awful to open a book and look for something that helps you to understand all of this mess you're feeling inside and find like 2 paragraphs on grief and 1 on loss. And think, oh, okay, maybe it's me.
Oh, wow.
Maybe I'm the problem. Yeah, it was something. And so finding this online community for parents of preemies was a lifesaver.
Oh, great. You found an online group at that time?
I stumbled upon it. I was searching for resources online, and there was a group called the Preemie List for parents of premature babies. And it was an international group, and it was a listserv. And it was the first place that I had found where parents were talking about everything
Wow.
that they were experiencing. And it was absolutely incredible. And it's actually out of that group and that experience that I really knew that this was the kind of work I wanted to do. It's how the book was born. The books, I should say, were born.
Mm-hmm.
And, just realizing that it wasn't just my NICU, it wasn't just my experience or our family's experience. It was from around the world. You could really hear from parents the same kinds of themes and the same kinds of struggles.
Wow. So not only, learning, how validating though to finally
It was.
hear from other people.
Yeah, it really was. It was one of those things that is like a good news, bad news kind of thing.
Sure.
Where it's like, oh, I'm so sorry. It's all these people, but wow, okay. This is real. This is really real. And this is where I also became really passionate about teaching, writing and teaching, doing workshops, going to conferences. I developed a doctoral level course. I realized it was 18 years ago now.
Oh, wow.
I'm just trying to dig up the syllabus because there was nothing. You get all the way through graduate school and there's nothing. Not just nothing about PMADS, but nothing about trauma, certainly nothing about perinatal trauma.
Oh, right. Yeah, I feel like it's gaining a little momentum now, but even, 18 years ago, sure, there was little to nothing.
Yeah. And I got trained in EMDR actually because of this population as well. Because, the skills and the framework that I had brought us only so far.
Wow. So you've been also doing EMDR as a practitioner for a while?
16 years. And I also do consultation. I'm a approved consultant, and I'm also an EMDR trainer. That's like the most fun, actually, especially teaching perinatal therapists. It's like puts all my favorite things in the same room.
That's great.
Really heavenly. It's great.
That's great. Yeah. And I can hear and see you're passionate about it, which just makes it so much easier for everyone else to learn. As you know, there's a lot to learn about trauma in the perinatal period, and we're going to get into some of that today.
Yes.
Okay. So I'd really like to understand from you, and I know there's so much to talk about here, just in terms of trauma in the perinatal period in general, and then how the trauma from NICU both affects parents and infants. So we're going to kind of get into some of that today to try and understand what that is, what the trauma is for the parents who are in the NICU, and what might be some of the trauma to the infant in the NICU and that interplay. Yeah. So if wherever you'd like to kind of dig in there, that'd be great.
Okay. So you're right. It is really complicated and it's multidimensional. And one thing that I do want to emphasize from the outset is that when we look at NICU, one thing to remember is you have the population of babies born early, premature babies. And you also have full-term babies who end up in the NICU for a variety of reasons, some of them very briefly and some of them for a longer period of time. So when I talk about the impact of NICU, I'm aware that, we really do have a tremendous range of the condition of the baby walking in the door, getting rolled in the door in their ICU. And even amongst preemies, baby born at 24 weeks gestation does not look, act, or respond like a baby born at 30 or 31 or 32 weeks gestation, or even 27. So there is quite a range. And so, there's a lot more nuance here. But when we look at, just in looking at the babies, when you look at the sequela from a NICU stay, the question always is, what is the result of the NICU environment itself? Things like sound, light, sleeping interrupted repeatedly, particular medications a baby might need, other medical interventions. And what is a result of prematurity itself, reasons for prematurity? For example, there might have been a uterine infection, complications of prematurity like a cerebral hemorrhage or infection in the NICU. Or for a full-term baby, what is the result of the reasons that they need the NICU to begin with? So it's difficult to tease out those factors. Right. Now, that said, there is a growing body of research looking at the impact of NICU itself on that raw nervous system of those fragile newborns.
Of the environment of the sounds and lights and whatnot that you were describing before.
Exactly. And, NICUs around the world vary tremendously in things like developmentally supportive care, clustering care, things like that are really designed to limit the impact on the nervous system And some NICUs will do some of those practices, but not all of those practices. And so there's quite a bit of variability there. So for example, compared to infants who do get individualized developmentally supportive care, infants who get traditional care, we see at higher risk of things like intraventricular hemorrhage, pneumothorax, severe BPD, bronchopulmonary dysplasia in this case, which is lung illness. They tend to stay on ventilators longer. They tend to stay in the hospital longer.
Can you clarify what you mean by traditional care?
Care like in the old NICUs, which are, they're sort of aging out. They're needing to get renovated because they've been around for so long. But the NICU that we were in, for example, was one enormous room. The divider down the middle was essentially the medical monitoring equipment.
Oh, gosh.
The room was lit with fluorescent lights. There was a loudspeaker where announcements were made, and the whole room could hear all of the announcements, all of the calls, everything.
Oh, gosh.
Right. And so that's just the environmental example of traditional care. Now, more and more people will have their babies in a pod, maybe 3 or 4 or 5 or 6 babies to a pod, depending on the environment.
Okay.
But even things like training in how to developmentally support a baby when you're changing their diaper, a 24-weeker or a 25-weeker, that's an example of, you would not believe how slowly it's possible to change a diaper. To really be containing that baby so that you don't inflict more stress while you're doing something so simple. Yeah, it really is something. And so we have that, just the stress of being either very tiny, not fully developed, or having some illness on one's development. So, I'm sure people have heard about, that we've corrected age for prematurity. If a baby is born 10 weeks early, let's say 3 months early, when they're 6 months old, we talk about them being 3 months old corrected age. We don't expect them to look like a 6-month-old.
Right.
Because they were early. Well, we don't just correct for prematurity, we also correct for time being really sick. If a baby's on a ventilator for a month, they're not doing much in the way of development. They're working really hard to breathe. So that energy has been redirected.
Oh, that's a lot to think about. I mean, and this is just, we're just scraping the surface of all of the factors here.
Exactly. And so if you think about, that you have this unfinished person or this very vulnerable little person entering this NICU environment unexpectedly very often, and the way that the environment itself can scrape the nervous system raw, not just the babies, but also the parents.
Yep.
And so we will talk about that in a little bit, about what that does potentially to the dance between the parents and the baby.
Yeah.
And so, long term, there's actually quite a bit that can happen after a NICU stay, after a premature birth. And it's complicated because I think people often are told, go home, treat them like a, quote, normal baby, which I could spend an hour talking about that. That comment.
Yeah.
But, treat them like every other baby, except don't expose them to any infection. Make sure everybody's washing their hands. Don't let any toddlers near them. They're at risk for this, that, and the other thing. And bring them back to follow-up care for 2 years, which, by the way, is not nearly long enough because it's at school age that very often we start to see those sort of secondary effects. Lots of preemies or babies who had NICU exposure.
For both short-term and long-term stays? Or
very short-term stays, less so, especially when there's some element of developmental care. But we do see that sensory mismatch to the infant's immature brain developing very rapidly. It can compromise their development, but there are things that we can do to mitigate that. And again, certainly as NICUs do more, that does help.
Can you explain a little bit more about sensory mismatch?
Yeah, so the kinds of things we were talking about a few minutes ago, the sounds, the light, the interruptions. So if a baby is sleeping and by the nurse's routine, it's time to do vitals or time for a blood draw, in the traditional nursery structure, they'll wake the baby. In a developmentally supportive structure, they won't wake the baby. They'll wait.
Wow, that's fascinating. Okay, right. So if they're using a traditional model, then they are interrupting the baby's natural patterns.
Exactly.
Gotcha. Okay.
Exactly. And certainly in an emergency,
Mm-hmm.
we're talking about something completely different. I'm talking about routine tasks.
Mm-hmm. Mm-hmm. Okay. So already I can hear how and why everybody might be really anxious and everybody
Yes.
might be traumatized. There's a lot. I mean, we're getting into some details, and certainly like as a parent walking into a NICU, you're not thinking of all of these factors. But this is why I think that kind of diving in and understanding these factors is important, because like you said before, that whole feeling of, I don't know, is this just me that feels this way? Well, the answer here, as we can hear, is no. There's going to be some impact on you and on your baby.
Exactly. And I also think that because, parents walking into the NICU are shocked, they're overwhelmed, and they want nothing more than for their baby to be okay and taken care of. And so when, as a parent, you have a protective instinct, very often people will hold back because the nurses are highly trained specialists. The doctors are highly trained specialists. Surely they know better.
Right.
And so the tendency to defer makes very good sense. But at the same time, it also can really inhibit a parent's growing sense of themselves as a parent to this baby.
Wow. Okay. So, right, just my mind went into all these like other implications that could follow because of that, which maybe we'll get into some of them, but sure, your baby's out and learning how to be a baby, and you're learning how to be a parent in this environment.
Right, exactly. And they don't look and act like, particularly if they're preemies, they don't look and act like the full-term babies that you most likely have been around, whether it's your own older child or another family member. All kinds of little nuances that are different, but even on a basic level, most of the time they will not have yet developed the ability to coordinate things like breathing, sucking, and swallowing. So before a certain gestational age, time-wise, preemies are not going to get fed by mouth in the NICU.
Right.
Now, that's a foundational thing that we do for our babies as parents. And so that struggle, but how do I parent? What can I do for you? You need this NICU. I'm superfluous.
Right. Everyone else is coming in and doing all the things to do the care or medical care.
Yeah. And very often, moms in particular will say that they want to stay out of the way because that feeling of their body having betrayed their baby can be really strong. Right. And so I've heard moms say, I haven't done so well so far, so I'm going to let the medical people take care of my baby. I don't want to hurt them anymore.
Oh, that's heartbreaking.
Yeah. And sometimes that's spoken and sometimes it's implicit.
Sure. That makes sense. So there's all this external stuff happening that is already overstimulating, and people might be withdrawing or just kind of disoriented by all of this.
Disoriented emotionally and disoriented pragmatically. When you walk into the NICU, you really need to let go of everything you thought you knew about babies, about how to be a parent. The things that might come, relatively naturally as a parent or just anybody near a baby can have the opposite effect on a baby in the NICU. Things that we would routinely do, like how you would touch your baby, that you might sing to your baby, that you might stroke your baby and rock your baby and sing to your baby at the same time. Well, that's going to induce a meltdown in a preemie. It's just too much sensory input. And so, unless they teach you or show you right away, sometimes a parent will reach in to touch the baby and the nurse will go, oh, no, don't do that. And so that feeling of, and the nurse just wants you to not overstimulate the baby. They don't want, because, with a preemie especially, one of the ways a baby shows stress is by having apneic episodes or bradycardic episodes. Bradycardia is when the heart rate slows down. And that's pretty scary, having the alarms go off.
Yeah. Oh, right. There's all the alarms, too.
All the alarms. So you reach in and touch your baby. Imagine, you're coming into the NICU and, brave parent who's like, well, this is my baby. I'm going to touch my baby. And the alarms start to go. Now, you haven't really hurt your baby, but you just didn't know.
Right. Yep.
How to do it.
Yeah. All right. So, you're speaking a lot to how vulnerable maybe is a better word.
Yeah.
And so you're speaking to how vulnerable the baby is, but also the parent.
Yes.
It's extremely difficult to know how to navigate when everything is new.
Exactly. And the thing about all of this that's really striking is that all of this is true even for a baby who's pretty stable.
Mm-hmm.
That's not even talking about a baby who's about entering, a really rocky NICU course.
Mm-hmm. Mm-hmm.
And then those ups and downs create, other layers of trauma, grieving, losses, challenges about how to be part of the healthcare team, how to engage as part of the circle of care around the baby, because parents are incredibly important in that circle of care. And depending on the culture of the NICU, it can be really challenging. Sometimes the response is almost as if the parent is trying to take their job. And I will often tell healthcare providers, parents don't want your job.
Right.
Parents are doing their job.
Right.
But they need our help to trust that they can do that job.
Right. I mean, the way I'm thinking of it as you talk about it is like, maybe this isn't the best analogy, but you're going into like another country where you don't know the language and nobody's telling you, you don't know what anybody's talking about.
Absolutely. The Welcome to Holland essay, which I don't know if people are familiar with. Are you familiar with Welcome to Holland?
No.
Oh, I'll send it to you. It was written by the mom of a little girl with Down syndrome many years ago, probably 25 years ago, 30 years ago. And it uses just that analogy. You think you're going on a trip to Italy and you're all ready to land, and the pilot says, we're about to descend and land in Holland. And you're like, I'm not going to Holland. I want to go to Holland.
Right.
Of course, parents of preemies say, we wanted to write one that's more like welcome to Uzbekistan or, Kazakhstan, because it feels more like a war zone in the NICU sometimes.
Mm-hmm. Oh, yeah. Gosh, right. So I'm imagining then with also the pace of a NICU and, the medical providers doing their work, doing their job, there's not a whole lot of time for slowing down and interpreting and explaining.
There are definitely times when it is like that where, and parents know, when something critical is happening and they step back and they're just in awe of and so deeply grateful. We're so grateful for the work that the nurses and the doctors are doing. And then, there are long periods of time for many babies that are, watching and waiting, growing. Even when there's an infection or there's a complication, there's still a lot of waiting. But the ups and downs, people talk about the experience of being on a roller coaster. The NICU is less like being on a roller coaster and more like being dragged behind the roller coaster.
Oh,
that's what people describe. There's just this feeling of being bumped and bruised, and it goes on and on. So it's really real, but people just plow forward.
Right. Getting from one day to the next is the goal.
And you begin to look at time in micro chunks.
Mm-hmm.
But it does make me frustrated when I see articles in the paper, about like, this is a revelation. Parents of babies in NICU have PTSD.
Mm-hmm.
Oh, guys, we've been talking about this for 25 years and longer.
Yeah. I mean, it sounds like for the longest time that same line has been towed around, like you have. I mean, I'm sure people get so many horrible comments like, well, at least you have your baby, or what, some other discounting type of way to just like, okay, well, you have this kid, so you should be happy, and totally discount the experience and the day-to-day.
Yeah. And go home and sleep is a favorite.
All right.
It's really hard to sleep when you're hypervigilant.
Yeah. Right. So the process is happening for the baby in the NICU, and the parent is trying to figure it out. I'm going to say, just in talking through this piece, they're both potentially traumatized, and then trying to navigate their connection.
Right.
Okay.
So here we have this baby, raw baby and raw parents trying so hard to get in sync with each other. It's so hard to get attuned to a preemie or to a baby who's ill because the signals are different. They often can't tolerate what we would naturally do. And, there they are in this intensive care environment, surrounded by all this high-tech equipment with really expert care. And so very often parents will hang back. They can feel really reluctant to approach their baby. I've had parents say to me, my baby doesn't need me. And of course, your baby does need you. And you need your baby. It was Donald Winnicott who said there's no such thing as a baby. There's only the mother-baby pair, parent-baby pair. And so how do you navigate that when your baby needs intensive care and you feel both grateful that the intensive care is available,
Right.
and also absolutely, how do I add? How can I help my baby and be a parent to this baby?
Mm-hmm.
And very often I hear parents and then also healthcare providers read this hesitation as lack of attachment.
Mm.
And while that's possible, I am more likely to explore this tendency in terms of the protective urge, which is actually a sign of attachment.
Mm. Thank you for that. I'm sure for lots of people listening, there's just like oh, right. Both for the parents listening in particular, right? Because you're speaking to so clearly to that, like, what do I do here? And it's hard to, I'm sure, interpret your own hesitation as a protection.
It's a protective urge, exactly.
Mm-hmm.
And so I will redefine that vigilance, or define that vigilance as a really important parental job. It's just that when you have a full-term healthy baby and you bring that baby home, the way that we experience that vigilance is very different
Mm-hmm.
than if our baby is medically fragile and in intensive care.
Mm-hmm.
And so I'll explain that parents will often avoid touching or caring for their medically fragile babies, not because they're not attached, but because they're so attached.
Right.
And that they're feeling protective, and they believe that their care would either not be as good as the expert care or could even hurt their babies.
Mm-hmm.
And so it's a sign of deep love and attachment, because you wouldn't be afraid if you didn't care deeply, if it didn't matter.
Right, absolutely. I'm just really hoping that the parents can hear that, who've been through this experience, because that's incredibly, I hope, validating for them.
I hope so too.
I mean, I'm just thinking of all of the moms that I've talked with, in my practice too recently. That hesitation is so real.
It is, and it can feel really shameful for some people, like, what's wrong with me? And people will often not say anything. They just step back, defer, hesitate, notice something, and don't say anything, because, again, surely they must know better. And, very often the first moments of really coming to feel like a parent to your baby are those moments when you kind of through that just a little bit. And it's one of those moments for me that I remember, and I'll share it. So my babies were about a month old, and they were still on oxygen. They were not weaning well from the oxygen. And I would spend all day in the hospital, and I would just sort of shuttle between their isolates, which were right across from each other. Mm-hmm. One day, one of the babies kept having desaturations, which means that her oxygen level kept dropping. Now, that isn't supposed to happen, and it hadn't been happening. It wasn't the first day in the NICU. It was within a month. And I kept watching her desat, and I said to her nurse, what's going on? Oh, it's a preemie thing. It's a preemie thing. Well, I've never had a preemie before. I don't know what a preemie thing is.
Right.
But she hadn't been doing it. And I just had this bad feeling. And I asked the nurse to ask the doctor, and she said, he said, we're just going to watch. And I kept watching, and I finally went to the charge nurse, and I said, could you page our attending? The way it worked was that whoever was, everyone got assigned an attending, no matter who was on call that day. Mm-hmm. So I knew that our doctor was in the hospital, the one that was overseeing their care throughout their stay. Mm-hmm. So she did. And then it was change of shift. And at that time, they kicked parents out during change of shift.
Oh, right.
Which, again, that's another developmental thing. So I'm pacing in the parent lounge, and in the doorway comes the doctor on call. And he says to me, we care about your little one. We want everything to be okay. We don't want to intervene. We're just watching. We're just evaluating. And I said to him, I didn't ask you to intervene. I asked you to assess. There's something not right. And I burst into tears. And I looked up, and he was gone. He ran away.
Wow.
And I said, okay. He said right before, he said, we're doing an x-ray. I said, great. Half an hour later comes the resident. He sent his resident. And he looked at me, and he said, she's got some fluid on her lungs. We're going to give her some Lasix. And I looked at him, and I said, I know. And I look back on that, and I think that was the first time that I really felt like her mother.
That's powerful.
That was really something.
Yeah. Right.
I was right.
Yeah.
I knew something.
Your intuition was working
Yeah. And I had given them that information and said, I'm telling you something is wrong.
Mm-hmm.
I'm the continuous variable here. I'm here every day.
Mm-hmm.
Just look.
Yeah.
And so we as therapists and the nurses and whatever role you have with parent of a baby in the NICU, you can do is encourage parents to notice their intuitions, notice their observations, and recognize that they're part of the healthcare team. And as part of the healthcare team, then again, they don't want the nurse's job. They don't want the doctor's job. But boy, coming to the nurse and the doctor and saying, I'm noticing something.
Mm-hmm.
I have a bad feeling. That's a really important job.
Yeah. And this is, like you were saying, the stark difference between how it used to be and what we're doing now or moving towards is that, doctor knows best and, parents are in the way and all this other business.
Yeah.
That's a beautiful shift in how we're caring for families.
It absolutely is. When we were in the NICU, we were not allowed in during rounds. And more, and it's been a long discussion in the NICU world about parents being present for rounds. And it's huge to be present, to listen to the report, to be part of the conversation. And it makes all the difference in that development of parental identity for this baby. I am a parent to this baby. There are things that I know. There are things that I do that make a difference and have an impact both on the baby and perhaps sometimes on the medical care as part of the team, because there are things that I can observe that others may not be in a position to observe.
Mm-hmm. Yeah, that's really powerful. So what have you seen and what can you speak to in terms of what happens for parents and how they work through this and heal through this?
Mm-hmm. That's a great question. There's a lot to say here about this, as you can imagine.
Yeah.
So just to frame it, remember that for parents, the sort of perinatal crisis interrupts the normal developmental twists and turns of creating a family, and it pulls them out of the normative world of friends and family. And so it makes them far more vulnerable. The first thing that parents lose in a perinatal crisis is their sense of safety. And then the second is their peer group. So the layers of loss and the potential layers of traumatic loss can be really nuanced and intricate depending on the particular family structure and the parent and, of course, what they come into this from before.
Mm-hmm. Can I ask about the peer group? Are you speaking of like other people who are also having babies, or just that they are now withdrawn from all of their supports that they had?
Well, the other people who are having babies. Mm-hmm. So, when you bring home a full-term healthy baby, as aggravating as it can be to be getting advice from every person who notices that you've had a new baby,
right,
including perhaps your mother-in-law or your mother, depending on the situation, you have some frame of reference for what full-term healthy babies might be like. Mm-hmm. You can ask advice if you choose to. You can ask your sister or your mother or your neighbor or your friend, did you ever have this experience? Did you ever have that experience? Well, most people have not had the experience of standing over their 2-pound baby on a warming bed and not knowing how to touch them, how to talk to them, how to feed them once they're able to feed.
Right. This is speaking to the broader, like, who do I turn to?
Yeah. And who's like me?
Who's like me? Mm-hmm.
Who's like me? Where are my people? Where are the other people who understand what it means to be worried about these particular things? Mm-hmm. To be worried about growth, to be worried about developmental milestones when the baby comes home, to be worried, about medical tests, to struggle to understand this whole new vocabulary, to have to figure out, as we did, how do you manage twins, 2 apnea monitors, and 2 oxygen tanks at home?
That's a lot.
It's a lot.
Yeah, that is a lot. And I mean, I'm sort of thinking too that you're also trying to figure this out while you're dealing with your anxiety or the trauma or the mental emotional piece of this, and
exactly
how much heaviness that could be, how hard it might be even to just think through stuff like this.
Absolutely. The alarm system that gets turned on during a perinatal crisis. And for some moms, it happens if they get hospitalized on bed rest. with complications, or if they're in and out of the hospital trying to prolong the pregnancy. It can happen sometimes much more quickly than that. You know, a precipitous birth, all of a sudden, boom, you know, we're having a crash C-section, there we go. And so if parents are experiencing a sort of classical PTSD symptoms, that also interferes, because you don't, as much as you don't feel like yourself in the NICU because it's so disorienting, you really don't feel like yourself when you're symptomatic with PTSD.
Right.
You can't trust your body the way that you normally would. You never know what's going to be a trigger. The sounds, the smells, that sort of thing.
Sure. That's quite a lot to navigate. And then, you know, there's the NICU environment. Then I'm just thinking, you know, the going to home.
Yeah.
And whatever's going on there, going back and forth between
And
those two.
Yeah.
That's its own thing.
Yeah.
And then bringing a baby home. I mean, there's so many transitions and processes that are happening all the time.
Absolutely. And the back and forth to the NICU when the baby is there is stressful, and then it becomes very often just the routine. The most stressful part for a lot of people is the time in between, you know, between when you're not there, when you don't have the nurse right there to ask a question to. But discharge and homecoming can be terrifying.
Sure.
You know, here your baby has just been in intensive care. Now, there's very often a step down, but it's still intensive care. They're still on the monitors. They still have a nurse caring for them. And then, you know, when they're ready, you know, they test out the car seat and they put them in the car seat and they say bye. And, you know, you walk out and you look behind you like, are they really going to let us leave with this baby?
Yeah, I heard that.
Are they for real? You hear that too?
Yeah.
It's wild. And then this fear of like, okay, they've had eyes on them for however many weeks it's been, however many months it's been. And now I'm supposed to take care of them? Like, how do you know I'm not going to screw this up?
Right. How am I supposed to sleep?
How am I supposed to sleep? And so part of this, you know, comes out of the stress and anxiety and trauma of the NICU environment. And part of it is, I think, the environment creates its own expectations.
Right. Sure. That makes sense.
So, you know, there's like two different kinds of aftermath of NICU. One is just the way your nerves are just, you're jumpy, maybe full-blown PTSD, maybe not, but still some, you know, symptomatic in some way very often. I'm worried, checking again, never sure. But then how could it be that it's okay to put my baby down to sleep and close the door? Right? Like the mismatch, there isn't much transition there, if at all. That mismatch of, no, we can trust that your baby will continue to breathe. We can trust that your baby is going to be okay, or else we wouldn't have sent them home. But that may not feel true yet.
Right. So that transition takes however long it takes.
But for some parents, I will say, they're like, we're home, it's good, we're happy, and that part's okay. And then they try feeding the baby, and then a whole other thing happens.
Right. So considering that, obviously we can talk about this for days, there's a lot to know. Thinking really specifically about the parents who are listening and, you know, trying to navigate this themselves right now.
Yeah.
What have you seen in terms of healing and being able to get through this?
Yeah.
What helps?
Okay. So what I think is most important is that we see parents and that they get to be seen as whole human beings. You know, it's so easy to forget that life could have been really normal for people before this happened.
Yeah.
You know, this could have been, you know, people functioning really pretty well and doing the normal things of life. And then the eyes that are on the parents very often are also concerned, anxious, evaluating, and so on. And so I think that we who are supporting parents, whether parent, grandparent, family member, healthcare provider, is that we only see the disarray and don't see the competence that's growing. And we have to see that both are happening simultaneously. And sometimes they oscillate. But to remember, this is a really hard time, but you know, I see you. I see you there. This person that is trying to find your way out of the rubble from the earthquake.
Yeah.
And that you have in there everything you're going to need and that you need now. to be the parent that you want to be for this baby, whether it's raw materials that are going to develop, like for any parent.
Sure.
Whether it's numbness that's temporarily protecting you from what might be unbearable in this moment, to look at you and say, I'm with you, and I'm not afraid of your fear, and I'm not afraid of your anger, and I'm not afraid of your grief, and I'm not afraid of your trauma, because all of that makes sense.
Right.
And you are not those things. You are experiencing those things, and they are real. And they will impact you, because how could they not?
Right.
And of course they will, and they should, because it matters.
Right.
And so you will be transformed, and that's a process. And that's really cool. And I'm going to walk with you as you walk this road.
Well, that's way more empowering than what I hear a lot of people experience.
Yeah.
I hope that people can, I'm hoping that people who support those who have had this experience can hear that specifically, that, that's empowering.
Yeah, that parents' reactions in this crisis don't reflect their overall capabilities. I mean, they need to know that we can see past the fragmentation, that we don't see them as incompetent when they're terrified. We don't see them as hostile or not deserving our care and nurturing when they're angry, and that we don't see them as helpless when they're shocked, when they're frozen.
Right.
And there's a parallel process here, because the more that we, and when I say we, I mean all of us, whether we're healthcare providers or friends or family members or whoever we are, that if we can provide relationship-based, developmentally supportive care to parents, helping to support their development as parents to this baby, we see them whole, even when they're struggling. This gives them more and more of an ability to see their baby whole, and not just see their baby as a list of medical complications or developmental challenges. Find the baby in there.
Oh, yeah. This is so empowering and such a vital information. And, if we can continue to wrap up our conversation here, this is, again, one small part of a much bigger conversation on other hopeful messages, other things that you think are empowering for parents.
Absolutely. Absolutely. So again, foundationally, parents need their strengths and capabilities, even if they're only just emerging, to be mirrored and recognized and held and nourished and nurtured. And these are the kinds of things that really help parents in their recovery, in their development, to hear that their longings for things to be normal make sense. And along with this, that they need to know that by wishing, for example, their baby didn't need intensive care, or that, in our case, for example, that they could wean off the oxygen, like that could it just be normal? Could our loving arms be enough? To be careful about calling something like that expectations, because it's really longings, it's really hopes. And so when you name it like that, it pulls on and helps to strengthen that quality and those feelings in the parent. Supporting and welcoming, to whatever extent parents have them, their desire to learn and speak the medical and developmental language, and to bring that to their healthcare providers, to support them in developing a role as active partners in their child's healthcare team. Because when you do that, you convey your confidence that their state of emotional disarray, wherever they're at that point, isn't permanent. Because that's the thing that we're afraid of course, is that the world has fallen to pieces, that we as parents have fallen to pieces, and that those pieces are lost. They need to know that we know that they're still in there, and that we can join with them even when they're feeling fragmented, and then also when they're feeling more competent.
Right. That's so important. I'm just going through some things that I've heard from clients recently, and it's mostly they're getting the opposite of this. Just people are discounting them a lot. And gosh, if we could just really stick with this mirroring and the developmental piece that you're describing, how much better it would be for the parents and probably baby too.
Oh, absolutely. Absolutely, because what happens then is that parents are increasingly able to interact with more fluidity and more calm confidence with their baby. They're not scared of themselves as much, and they're not scared of their baby as much.
Yeah, that's so important.
And so learning how to do the things that, you would think of as like what parents of full-term healthy babies get to do, what feels like normal, that drive is a healthy, normal drive. And it coexists with that desire also to modify and change whatever you need to so that this works for your baby. And again, those coexist. And so the desire, for example, to be able to nurse, this is one of the big ones, how to get a baby to breast from the NICU. That desire is a normal, healthy desire. And that growing alongside that growing awareness of like, this is more complicated. And it's complicated for a lot of full-term healthy babies. So just imagine.
Right. Right.
And that parents' desire to retain a sense of competence is also healthy, to feel like, well, I do know something, and here's what I'm observing, and here's what I know about my baby. And to make space, to hold space for all of that emerging competence and recognition of attachment urges that look different when your baby is in NICU or discharged from NICU. And to know that those moments of grieving, the triggers, the post-traumatic triggers, do not invalidate the strengths, the coherence that's also there, the cohesiveness rather, that is also there for parents. And this is what's hard, is you're holding both. You're holding both the parent, and the baby is an example of that. Baby may have an immature nervous system, but just be needing to grow, or baby might be full term with a medical condition that needs care. So baby also has a variety of pieces that they bring to the table. And so how do you not hyper focus on one? Right. So there's all these parallels.
Yeah, absolutely. I mean, all of what you're describing, I appreciate you so much for going into depth in some of these places where we can, for those of people who've experienced this and for people who haven't, to find a place of compassion and understanding for themselves and for others. I mean, that's key here in all of what I hear you saying.
Yeah, I think that's absolutely right. Compassion and not losing sight of the whole person. It happens in these really subtle ways in the medical system in particular. When I was hospitalized really suddenly. I'd gone in for a regular ultrasound and check, and I was in preterm labor. I was already starting to efface and dilate, and they set me up to labor and delivery, put me on a monitor, put me on magnesium sulfate, and I thought, oh, how long will I be here? Do I need to cancel all of my appointments for today? And the nurse is like, And I had been teaching graduate students. I was in the middle of a semester.
Oh boy.
And weeks go by, and I didn't hear anything from my students. And then about 5 weeks into my 6-week hospitalized bed rest, a nurse hands me a card, and it's from my students. And I looked at the postmark, and it was easily a month earlier. And I looked at her, and she said to me, nobody could figure out who Dr. Stein was.
Oh.
Because I was a patient.
Yikes.
And there you have it, right?
Oh, goodness. Right.
Yeah. And there's this, blending of person, professional person in the world, and then mother, father, which may be just emerging. They both matter. They both count.
Yeah, they do. Well, thank you so much for all of this information. And when we wrap up, I'm going to point people to the books that you have, are a wealth of information also.
Many pages.
Yeah. I was like, oh my goodness, when I saw that book, it is hundreds of pages and such a huge resource to everyone. So I'll give everyone that information. And thank you so much for your time and your expertise and your passion for this work. I really appreciate you helping us understand this more deeply.
It's really a pleasure. Thank you.
Thank you, Mara, for coming on. For those of you who are interested in getting in touch with Mara, you can go to www.docmara.com. I want to make sure to give you those 2 books that she's written. The first is Parenting Your Premature Baby and Child, The Emotional Journey. And the other is Intensive Parenting, Surviving the Journey Through the NICU. These are great books, really supportive if you're trying to understand and navigate your experience through this and are supporting parents through this. Hopefully you can check out those books and get these great resources to support you or the people you're supporting. If this is your first time joining us on the Mom and Mind podcast, Please pop on over to momandmind.com to find links to all of our social media or links to where you can listen to the podcast and subscribe so you can get each of these episodes downloaded to you directly. Mom and Mind is also part of the Parents on Demand network, where you can find a lot of early parenting podcasts to support you in your journey. So glad you could join us today. Until next time. Thank you so much for joining us today. Please share this podcast. Together we can support moms and families so that no one has to deal with this alone. Come connect with us at momandmind.com.